Good evening. Good evening to one and all. I'm Dr. Sanjay Chaudhary from the Medical Affairs team of Sun Pharma team. It gives me an immense pleasure to extend you all a very warm welcome on behalf of Sun Pharma for today's medical webinar on individualizing type 2 diabetes treatment with both old and new therapies. And for that, we have two eminent diabetologists, Dr. Vivian Fonseca sir and Dr. Vijay Negalur sir. Before we start, let me give a short overview on the Sunkalp initiative. Okay, Sunkalp initiative by Sun Pharma has been created for handling lifestyle diseases like diabetes, hypertension, asthma, and GI disorders. Sunkalp, the word Sunkalp comes from the Hindi word which means pledge or for patient care. Promise of Sunkalp programs helps you be the first but also the best in dealing with the patients with lifestyle disorders. Through Sunkalp initiative, we aim to partner with doctors in their endeavor to offer quality healthcare. So there are multiple arms of Sunkalp initiative. We'll be regularly updating you on the global accredited CME modules, Indian and global therapy expert videos, recent articles from best scientific journals, interactive webinars, etc. via calls, emails, SMSs, and WhatsApp, which will help manage patients better in the area of these diseases. So as promised, today we begin with our first webinar, which is related to the diabetes, as it is in line with the World Diabetes Day, which was celebrated in November 2021. The topic for today's session is individualizing type 2 diabetes treatment with old and new therapies. This is in line with the utmost importance or the utmost response or the feedback that I have received from multiple clinicians, considering there have been so many new molecules and new guidelines that have come up in the last few years. And I'm very fortunate to introduce our two eminent diabetologists over here. Our guest speaker, Dr. Vivian Fonseca, who is a renowned diabetes care expert with extensive experience in the field of diabetes. Along with Dr. Vivian Fonseca, we also have our faculty, Dr. Vijay Negalur, sir, who will be moderating today's session. So please help me in welcoming these personalities. Before we start, just let me introduce our moderator for today's session, Dr. Vijay Negalur, sir. Dr. Vijay Negalur, sir, is a senior consultant diabetologist at Jupiter Hospital, Thane. He is a honorable associate professor of medicine and has served as an examiner and convener for MHS. He is currently one of the leading teachers in the Public Health Foundation of India and currently teaches on a variety of subjects, including diabetes, thyroid, pregnancy in diabetes, and cardiology and diabetes. He is also the director and faculty for Education Society for Study of Diabetes. He is also the founder president of Association for Diabetes Care and Prevention since 2000 till date. On a personal note, I am privileged to introduce Dr. Vijay Negalur, sir, as sir is also my teacher during my MBBS days. Welcome you, sir, and without taking much time, I'll hand over this session to you.
Thank you. Thank you, Sanjay, for very, very kind words of introduction, and thanks for the invitation, Sun Pharma, for this great meeting on the eve of the World Diabetes Day. We all know the management of diabetes has undergone a tremendous change, and this has brought in a paradigm shift in management of diabetes. Until 2008, we used to say that the glycemic control is the key factor in controlling diabetes, and we realized in 2018 that glucose-centric is of no use. We need to have no hypoglycemias, no weight gain. And then the concept of organ protection came in when we thought we have to have a cardio-renal metabolic attitude towards management of diabetes. And therefore, this has gone a lot of changes in management of diabetes. And this change of diabetes requires a regular update. And therefore, we are so fortunate to have such a renowned speaker, well-known all over the world, and that is Dr. Vivian Fonseca. He is the living doyen in the field of medicine and diabetology and endocrinology. Dr. Vivian Fonseca is the past president for Science and Medicine of ADA 2012 and has served as ADA Board of Directors for several committees, including American Board of Internal Medicine. Served on board of directors of the American Association of Clinical Endocrinologists and a board of trustees of the American College of Endocrinology. He has played a significant role in developing guidelines for treating diabetes, both at the ADA and ACE, and managing chronic diseases and clinical trials after a natural disaster, and is drawing attention to the global epidemic of diabetes, particularly in Asia. And he has plenty of awards to his credit: the ADA Banting Medal for the leadership and his service, and the Southern Medical Association awarded him, and the Seal Harris Award. Published nearly 500 papers and review articles, and he's editor of the textbook of clinical diabetes, which I've read. It's an extremely good book, and one must have this book in everybody's library, and translating research into practice, and several monograms and book chapters. And today, Dr. Vivian Fonseca will discuss with us on individualization type 2 diabetes treatment with old and new therapies. May I request Dr. Vivian Fonseca to start his deliberation? Sir, the floor is yours.
Thank you very much, Vijay. And I also would like to thank Sun Pharma for organizing this today, importantly recognizing World Diabetes Day. And I also want to point out to the audience the many years of work that Sun Pharma has done globally for the cause of diabetes, partnering with multiple international organizations, including the ADA. And I have visited as part of the ADA team on many occasions. Unfortunately, I can't visit today to be with you live in India, but I'm glad that we have this technology to do this lecture via Zoom. So thank you very much. So let me now try to share my screen so that we can move on with the lecture. And okay. I hope you can see the screen okay?
Yes, sir.
Okay. So let me move ahead. And as you heard, we're talking about individualizing type 2 diabetes treatment with old and new therapies. I think it's very important to recognize that we still have some of the older therapies that we should not forget about. And I'll highlight their importance in the early part of my talk and try to then go over and review some of the newer therapies. But all the time we should recognize that most of the patients in the clinical trials that have established the value of the new therapies with wonderful trials like EMPA-REG and DECLARE, etc., had in the background all these old therapies still present there. Most patients were on insulin. About half were half were on insulin. Most patients were on metformin. Several were on sulfonylureas. So it's not as if we have to discard those therapies. So here are my disclosures. I've been very fortunate in participating in the development of many of these things we're talking about and being part of those clinical trials that has led to a really major paradigm shift. The ADA clinical practice guidelines a few years ago changed quite dramatically, trying to develop a more precision type of approach, just like we have precision approach that's become very prominent in treating cancer, for example. You have a particular type of cancer, particular mutation, you'd use a particular treatment rather than the one glove fits all type of chemo that was not really working. And now we're seeing tremendous advances in some types of the disease. A similar shift is occurring in diabetes, but we aren't quite there yet. We still have to be a little bit more precise. And I'll point out areas where we really could do better, as well as maybe take a pause of being over enthusiastic about this guideline because it's got some weaknesses. Just want to point out that all these new therapies are on the background of first-line therapy, which is up there, which is lifestyle change, a comprehensive lifestyle change, as well as metformin as the background. And there is some controversy about whether we should have other drugs as first-line therapy, and I will come to that. But then when metformin fails, as it often does, you have to ask the question, what does my patient have? What's their clinical features that are compelling us to change and add on a more precise therapy? So one easy consideration is, do they have ASCVD, heart failure, or CKD? Now, you may think it is easy, and it is not always easy. It is easy in the case of CKD because you do a simple blood and urine test and you have the answer. If you have GFR less than 60, you will get the answer, and you have CKD as defined. You have even a little above CKD 60. If you have proteinuria, you clearly have CKD, so you should treat accordingly. But recognizing risk of heart failure and recognizing ASCVD in people who've not had a prior event is somewhat problematic. And then, so if patient doesn't have that, and there are a lot of people who don't, you want to minimize hypoglycemia. This is particularly a problem in older people who have erratic, or people who have erratic eating habits, and hypoglycemia is a big problem, especially if they've had it in the past. And the other choices between DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitor, and thiazolidine-down. That's very easy to recognize. You also have some people where minimizing weight gain or actually promoting weight loss is the major consideration. We see a lot of that in the United States, and I think you do to a lesser extent maybe in India, but I think obesity at less levels of BMI than you see in Western countries is very important in the Indian population because of accumulation of fat in the liver and the heart, etc. And there, GLP-1 is the most effective, but SGLT2 inhibition is more consistent, although the weight loss is modest. And finally, we all across the world have a major problem with cost. And I'm sure you have it with many people in India. We certainly face it in the US. The pandemic has made this problem worse. And when cost is a major issue, the guideline says consider thiazolidine-down or sulfonylurea. I want to point out that although the guideline says you only use these drugs when cost is an issue, there are some other things that we are being forgotten here that bring these drugs actually forward where you can use them. And I'll point that out as we go along. So let me address the first question. CKD, I told you, is easy, but what about heart failure? How do you recognize who's going to have heart failure or not? And that's a big challenge. SGLT2 inhibitors are clearly the drug of choice there, and I'll show you some of that data. And then you have ASCVD. Now, if someone has a prior MI, it's very easy. But in someone who has no prior MI, you could say that this person is at risk based on risk factors, as has been done in DECLARE and REWIND and trials like that. But then it takes many years to see the benefit, and the cost effectiveness is a little unclear. Once you have atherosclerotic disease, I think GLP-1 receptor agonists are actually better in reversing atherosclerosis as compared to SGLT2 inhibition, which is better for preventing heart failure. So why have we changed all these guidelines? And one of them, clear consideration, is heart disease and stroke are doubled in diabetes. It's the leading cause of morbidity and mortality. Kidney disease is also a problem. And we have these wonderful trials that have pointed out positive results with some, but not all the drugs. So there are drugs in these classes that did not have outcomes showing benefit in the trials, partly related to the population they treated. And that brings me to another important consideration. Who has these severe problems? So this is a breakdown. A few years ago, an analysis in the United States looking at prevalence and co-prevalence of comorbidities. I think it's a very important consideration. So if you look at the people who have CKD and CVD, the population that was extensively studied in these trials, it represents only 8.6% of the population with type 2 diabetes in the United States. It's actually a very small proportion. But these are the highest risk patients. It's important to recognize them because they really need special attention. Otherwise, they will have a bad outcome in a short period of time. And you see those bad outcomes in the placebo groups in the trials. Then you have a group of people who have CVD but no CKD, just say myocardial infarction alone. And there, I think the focus should be on anti-atherosclerotic therapy. And we should not forget that in both these groups, blood pressure lowering is important and LDL lowering is also important. Maybe treating triglycerides is also important. And I don't have time to go into those today, but you should keep that at the back of your mind. And then finally, in 15% of people, there's CKD, and they say no CVD because they can't recognize this. People with CKD have a very high rate of CVD, which may not be currently manifest. So either you need to look for it, or you should perhaps assume that this group has a high rate of background asymptomatic CVD. But this brings me to the most important group that you are seeing in primary care a lot, and that is over 60% of people have clearly got no CKD and no CVD. Now, does that mean we don't use GLP-1 and SGLT2 inhibition in those? Of course not. You can if you want to for other reasons, but I think it is important to recognize that the vast majority of patients were not included in these CV outcome trials, and we need to have therapies for them, including some of the older therapies. So let me start with metformin. Still, there's some controversy. Should it be first line or not? It has modest efficacy. It has no effect on beta cell function that continues to progress. It's seen as causing weight loss, but the weight loss is very modest. There's minimal data on CV benefit. In fact, the Origin trial showed that there was no difference between starting metformin or starting insulin. There's no microvascular benefit shown even in UK-BDS and other studies. You get vitamin B12 deficiency. You have some problems with tolerability. People, yes, it maybe decreases mortality, but you get this tingling, numbness, maybe dementia from B12 deficiency. But this is very cheap. And as I pointed out to you, there are maybe better alternatives, but all those alternatives were studied on the background of metformin therapy. However, since we are talking about a precision medicine approach, I would think that if you have a person who is got diagnosed with diabetes and has not yet had any treatment, you could consider that if they've had CKD, PVD, you should consider GLP-1 receptor agonist. If they have CKD or CHF, even without diabetes, you may want to consider an SGLT2 inhibition because that is now very established as being effective for these even without diabetes or as the first-line treatment for diabetes. For people with stroke, as I will show you, Pioglitazone is important. And for the rest, any drug, including metformin, is good. So you can take what you want for first line, but the long safety of metformin is very established. But what is the best add-on therapy? And for this, at the ADA meeting, the GRADE study was presented. This is an NIH-funded study. It showed that it was designed to demonstrate what to do after metformin in terms of glycemic control. Because let me disagree, and we'll come up in the discussion time about what Dr. Negalur just said, that maybe glycemic control doesn't matter. I think it does matter. It matters for microvascular complications. It doesn't matter for cardiovascular. But for those 63% of people, you want to prevent them getting retinopathy and neuropathy and so on, and so glycemic control will matter. And these are people who failed on metformin after initially responding. So they were randomized to receive either sulfonylurea, glimepiride, or DPP-4 inhibitor, sitagliptin, a GLP-1 receptor agonist, liraglutide, chosen because that is what was available when the study started, and insulin glargine. And at the time this study was started, I was an investigator in this trial. I remember that people were not sure about SGLT2 inhibitors. It had just come on the market, so it was decided not to include it. I think it was a mistake, but people are hesitant about doing large trials with new drugs. And the primary outcome was failure again, getting control with the combination and then failing. And here you see the results. And actually, the thing about these results that is striking is very disappointing, that within a 3 to 5 year period, your second line therapy is also failing. Now, they draw attention to small differences that they are statistically significant. For example, sitagliptin, 77% of people failed. But at the end of the day, it's not that much better with liraglutide because 68% are failing there, and there's not much difference between liraglutide and glimepiride. And even on insulin, people improve their control, but then A1C goes up above 7%, and you're maybe limited by patients' reluctance to increase dose or getting hypoglycemia, as I will demonstrate in a case. So let me turn then to sulfonylureas, which actually didn't do too badly in this previous study, in the GRADE study. There were no difference in cardiovascular outcomes in that study, and these are people with early diabetes. So where would you use sulfonylureas? So from a precision medicine approach, there is one indication where you must use sulfonylureas, and that is a condition called MODY, maturity onset diabetes of the young. It is a little bit more common now than what we used to think. Certainly people with a strong family history. We are actually doing some genetic screening in some patients. It is very expensive today, but you can do targeted screening. And particularly some kind of mutations such as the HNF mutation and the potassium channel mutation are very specific. They respond extremely well to sulfonylureas. They include, many of these children who have been treated previously with insulin, and they can come off insulin and be treated with glimepiride. The other very important trial that was sort of neglected, and we need to see more of these trials, these so-called comparative effectiveness trials, where all the other trials were compared against placebo, but we don't use placebo in practice. You want to compare it with your choices that you have. So they took people failing on metformin, based A1C above 7, and they were randomized to receive either linagliptin or glimepiride. And as you've seen in other trials such as ADOPT, etc., sulfonylureas work very well, very quickly, and then you get some degree of failure over time. But it takes about 3, 4, 5 years before you're back to baseline. So it's not, I don't think it's that the drugs are failing. I think the problem is that the disease is progressing. But importantly, no difference, as you saw in GRADE, between sulfonylurea and linagliptin. The important question was, does it make a difference to cardiovascular disease? Because people used to think that sulfonylureas have an adverse cardiovascular effect. But here you see no difference between linagliptin and glimepiride, identical after several years of follow-up. And I think it's important to recognize we consider DPP-4 inhibitors as safe. Glimepiride is also safe on reducing MACE. No difference between the two. No difference in mortality. So this establishes glimepiride as being safe. It is effective for a certain number of years, particularly early in the course of the disease, and dispels any myth that you increase cardiovascular disease. Let me turn to another old drug that is relatively cheap, and that is Pioglitazone. We did the Proactive, which was the first cardiovascular outcome trial done that was negative because they had a very broad outcome. If they had used MACE, as we did in the other trials, it would have been statistically significant, and we would be using Pioglitazone as a cardiovascular drug like GLP-1, RA, and SGLT2 inhibition. But in a subset of people who had a previous stroke, you saw the greatest benefit of 47% reduction in further stroke and in MI. But this is a secondary analysis, post hoc. People don't give it much importance. So NIH did another study. They took people who had diabetes, not diabetes, but pre-diabetes, insulin resistance, and previous stroke. And they were randomized to Pioglitazone and placebo. And there was a almost 30% reduction in a second stroke or myocardial infarction or cardiovascular events. Very good result for Pioglitazone in stroke patients. So I think this should be brought to the forefront in people with stroke to prevent further cardiovascular disease. So I want to now illustrate how we use all these drugs and other drugs in the setting of clinical practice in individual patients. And the first one I want to start with is a very common scenario of people with type 2 diabetes who have uncontrolled type 2 diabetes on two oral antidiabetics. So I'll summarize for the sake of time very quickly. A 48-year-old patient with type 2 for 11 years, also got hypertension, hyperlipidemia, hypothyroidism, taking maximum metformin some glimepiride, and doesn't want to take too many medications, feels it's very burdened, but agrees that one more may be better, but doesn't like injections. She also takes simvastatin, drugs for the lipids and blood pressure, etc. BMI shows obesity, 33 BMI, blood pressure is a little above goal, A1C is very much above goal, 9.4%. Lipids are not bad, but LDL could be a little bit better. And the GFR is 48. This is a problem patient. Even though there's no overt CVD, this patient has got CKD. So what therapy would you add next? And here's the choice. There are many agents that you could use. And I could add in some more, but I've just limited it out there. And I think the important thing to recognize, based on CKD today, based on the guidelines and based on what the trial results would show, that you got CKD, you should have an SGLT2 inhibitor. But let me remind you that this patient's A1C is 9.4, and you have a goal of being closer to 7. You're not going to make it with an SGLT2 inhibitor. This patient has obesity, so maybe a GLP-1 receptor agonist would be useful, but it's expensive. Patient is hesitant about it. What about a DPP-4 inhibitor? I think you're not going to get to goal. What about basal insulin or premix insulin? I personally prefer, for many years, basal insulin rather than premix based on 4T. But now we have fixed ratio combination of insulin and GLP-1, and we showed that you get better control with less hypoglycemia and weight gain, but this combination is not yet very, very popular. So we have modern basal insulins that are very cheap and easy to use. I won't spend time on that. We are using mainly glargine U300 and degludec because their hypoglycemia rates are lower and they're easier to use. This patient, unfortunately, was started on U300. Oral agents were continued. She went up on the glargine to 48 units. Blood sugar was still not totally controlled at around 120 with an A1C of 8.1, but the patient had weight gain and one episode of hypoglycemia. This is a major limitation in the therapy. And the guideline says, again, you could choose adding in a prandial insulin, which is falling out of favor because we tend to use more GLP-1, or you could use premix, which you use a lot of in India and Asia, but it's twice daily and you get more weight gain and more hypoglycemia. So you really have a dilemma there. The GLP-1 RA has become very much a treatment of choice, and the ADA guideline says maybe consider it as the first injectable if you're going to use it. Let me move to another kind of patient. Patient having other comorbidities, cardiovascular disease, heart failure, CKD, something that's got a lot of attention recently. So here's a patient. He's a male, moderate obesity, but fasting glucose is high, A1C again 9.4, postprandial is very high, 15 years of diabetes, his age is 70. He too has CKD with proteinuria. He's got some retinopathy, he's got hypertension, dyslipidemia, had CVD, 2 stents, has a carotid bruit, is currently taking metformin, sulfonylurea, and a DPP-4 inhibitor. 3 medications, and yet the A1C is 9.4 because of the long duration of diabetes. And medicines haven't been changed in 2 years. This is a common problem of what we call clinical inertia. We really need to do something. So my call to you on World Diabetes Day is don't let your patients remain uncontrolled. Do something. Don't wait 2 years. But you want to avoid hypoglycemia, and this patient fears it a lot. And so the choice here, really based on that profile, is GLP-1 receptor agonist or SGLT2 inhibitor. The patient can only afford one or will only take one more. And so we need to make a comparison between these 2 new medications. And there are a lot of differences. GLP-1 receptor agonists are very powerful on A1C lowering. You can get up to 1.7% reduction. You can occasionally see that with SGLT2 inhibitors, but not that much. On average, it's 0.6 reduction. You could get more weight loss with GLP-1, but it is variable, and you get more consistent but less weight loss with SGLT2 inhibitors. You get more blood pressure reduction that's consistent with SGLT2 inhibition. You might get some with GLP-1. In terms of glucose lowering and satiety and all that, GLP has some advantage. Hypo, fortunately, is low with both. Both have significant side effects for tolerability. A lot of GI problems, and people stop taking the medication with that, and also with SGLT2 inhibitors, some genital infection. Injection may be a barrier, but we are using a lot of once-a-week injections, which people are willing to accept more as compared to the twice a day that we had before. And the ability to reduce cardiac events is really very important with GLP-1. I think because this patient has a carotid bruit and a stent, I would really consider this strongly with the high A1C. On the other hand, if there's any hint of heart failure, I would consider an SGLT2 inhibitor. And also because of the kidney disease. There are kidney trials going on with GLP-1 receptor agonists, but we don't have the results. I'll walk you through very quickly the summary of all these trials. Leader trials showed what I think is important, a consistent lowering of all segments of MACE, as well as reduction in nephropathy. So this indicates a very broad anti-atherosclerotic effect. Semaglutide is very powerful, a very quick effect. This study was very short term. It was done more for safety. We don't know what it does to, it didn't reduce mortality. We don't know about the EMI. It was reduced, but not significant. The major effect was on stroke. No effect of GLP-1 receptor agonists on heart failure. It's important to recognize that. The downside is, again, positive results on all aspects, but retinopathy worsens. So this becomes a trade-off. You're doing good for the cardiovascular, which is the prominent issue with this patient. But he's also got retinopathy, and that might get worse. And I think you need to have this treated before considering a GLP-1 receptor agonist. Dulaglutide took more primary prevention, people without a history. And year 2, you see some benefit, but it took 6 years to see the benefit, which was small, and there was no reduction in mortality. The really striking reduction in mortality was seen in the EMPA-REG trial, where death from any cause was significantly reduced by empagliflozin. Hospitalization for heart failure was rapidly decreased relative to placebo. But I also want to point out that in this very high-risk people who had a previous MI, the rate of hospitalization for heart failure is very low. So the absolute risk is actually very small. And the reduction in myocardial infarction was actually very small. So it's a question of what you want to use the drug for. Is it preventing MI or a stroke? In that case, you should use GLP-1. If it's heart failure or CKD progression, you should maybe use a GLP-1, an SGLT2 inhibitor. And use the canagliflozin trials, and some of that related to not only drop in A1C, but also some weight loss and a significant reduction in blood pressure from, I might point out, a very high baseline. So the placebo group had a baseline of about 136, 137. To me, that is too high, and we don't know what would happen if we had reduced this blood pressure somewhat. DECLARE was with dapagliflozin done in a more primary prevention cohort. 2/3 had never had a previous event, and so you had no reduction in death. You did have some renal benefit, and you did have some reduction in hospitalization. It took longer to see that, and there was no reduction in MACE. So differences between different outcomes that are important. So meta-analysis of all these trials showed that in patients with established ASCVD, you got a benefit in hospitalization for heart failure. You got a small benefit with MACE, especially in CANVAS. But in people where you're looking at primary prevention, you actually don't see that. But you do see the benefit on heart failure. So in high-risk patients with prior MI, MACE is reduced with DAPA, but not in people who have no prior MI. But the heart failure benefit actually remained, and there was a kidney benefit. So again, for heart failure and kidney disease, these SGLT2 inhibitors are very, very good. There are multiple mechanisms that have been invoked that I don't have time to go into. We could take some of them in the discussion later on. But because of the benefit on renal disease that was seen initially in those cardiac trials, renal trials were done. So here's Credence, and there's now DAPA-CKD and an EMPA trial. But Credence showed a very clear reduction in the progression of kidney disease that was statistically significant. And that is in that renal population, there's a lot of cardiovascular death and cardiovascular events, and that too was reduced. So for people with CKD, we should give very careful consideration to SGLT2 inhibitors. All of them lead to a benefit. And yes, it's shown in a meta-analysis showing a reduction in the progression of GFR loss. There's been a very recent development. I don't know if you have it yet. In the United States, we have a new drug called Fenerone. This is like spironolactone, but a very selective mineralocorticoid receptor antagonist. It does not cause as much hypokalemia, does not reduce blood pressure very much, but decreases inflammation in the kidney, and you get a reduction in progression of chronic kidney disease, as well as in a reduction in cardiovascular events and death. Heart failure remains a major consideration in type 2 diabetes, particularly with patients who have previous disease and very poor control. I want to point out that you should avoid thiazolidine downs in those patients. The metformin is relatively contraindicated only in people who have symptomatic heart failure, not in people who are stable. And SGLT2 inhibitors are the best option. And very recently, in Emperor Preserve, they showed a benefit of reducing hospitalization in HFpEF, which is a very new finding, the first drug to show some benefit, but it did not lead to a reduction in symptoms and a reduction in mortality. So there's still some questions in regard to that. Overall, in EMPA-REG, heart failure was a clear benefit, as you've seen. I want to remind you that we need multifactorial risk reduction. Just treating one thing at a time is not good enough. And STENO2 showed a reduction in blood pressure, in lipids, and glucose, and that led to a very big absolute risk reduction, far more than in any of these other trials. And I strive for this. This has been shown in Europe in the ADDITION trial and in China with a study called RAMP-DM. So I think we should go for multifactorial risk reduction. Let me take you to the last patient, and I put this towards the end because it's slightly different, and that is talking about glycemic variability. You see this a lot, particularly in people who have high carb intake at meals, like in India. A1C is good, but even if it's slightly bad, you're seeing a lot of postprandial glycemic excursions. And we often don't recognize this if we only do monitoring in the fasting state or pre-meal. And postprandial glycemia is very important. It's related to a number of abnormalities in the pathophysiology, lack of secretion of insulin in response to a meal, and lack of benefit of its effect. Too much glucagon, too much of a large meal with a lot of carbohydrate. And it's also regulated by the preprandial glycemic level and gastric emptying. So now we have tools to recognize this. And the tool that we are using a lot of is continuous glucose monitoring, which I understand is now available freely in India. It is still somewhat expensive, but it is rapidly catching on because of the ability to recognize these highs and lows. So yeah, our aim is to have a target range of 70 to 180 over 70% of the time. And here we have a patient, 59-year-old male who's on basal bolus therapy. A1C is not bad, but he's getting some hypoglycemia at night, and it's causing him some disturbance. Also, sometimes his blood sugar is very high. So if you look at his glucose profile, you see it very clearly. He's going low during the night and occasionally during the afternoon, sometimes going very low at night. And he's clearly going high after meals. So you have a conversation with this patient as to what's going on. Maybe reduce the insulin at night, maybe have a bedtime snack, reduce the carbohydrate with meals, or adjust the therapy at meal times to control this better. And you can identify certain days when it's a problem, where the patient had particularly large meals, and it helps teach us and teach the patient. The disease is very different. Everybody's different. We need a more precise approach. Patterns vary a lot, but it tells us what's going on in an individual patient. It helps patients recognize the elements of diet and stress that have a considerable impact on their glucose patterns and allows them to take corrective action. So it allows an effective and personalized treatment strategy, along with the kind of hints that I've given you for choosing the right treatment for the right patient. I think we can have a very personalized approach. Clinical trials results apply to the type of patients studied in the trials, not everybody. So SGLT2 inhibitors, great for CKD and CHF, mostly for secondary prevention. For CHF, it clearly is clear, and you need to avoid TZDs. They are not so effective in stroke. For stroke people, maybe semaglutide or Pioglitazone. Sulfonylureas, Vesfamody, almost as good as DPP-4 inhibitors, maybe for glycemic control, even better. But you need to recognize hypoglycemia, and CGM is an important tool there. And we should also recognize other risk factors, and maybe we need to predict events better, and we are working on that. And also recognize that some people have atypical diabetes, and we need to use appropriate therapy there. So I'm going to stop, and I hope we have plenty of time for a good discussion, take some of your questions, and I'll hand it back to Vijay.
Thank you, Vivian, for an amazing lecture. And you really covered almost all the aspects of management of diabetes, especially from the cardiorenal and the metabolic angle. And you covered almost all the drugs, the old and the new. A very comprehensive discussion. It's a fantastic talk. I think I'll turn to Dr. Sanjay. He has got some questions in the chat box. Can you please read them and decide who should answer?
Yes,
send it back to you.
Sure, sir. Of course, sir. So thank you. First of all, thank you for your wonderful presentation, sir. So we have received multiple questions, but we have filtered out which we can address today. So one of the questions which I would like to help answer from both of you is how frequently to monitor these parameters, specifically HbA1c and the other parameters related to diabetes.
So the recommendation, A1C reflects blood glucose control over the previous 3 months. It can be up to 4 months, but it's not very good. It's really a 3-month control. So in an ideal world, you would do it every 3 months. However, the guideline says you should do it at least twice a year. That's the minimum. If I'm seeing a patient 3 monthly, that's when I do the A1C. I try to do it in everybody every 3 months. I want to point out that there are some situations where A1C is not good, and that might be quite common in India. Anemia, for example, maybe advancing CKD, hemoglobinopathies, etc. These are not uncommon. And in that case, you should recognize where there's a discrepancy. And we're seeing this when we do CGM. In CKD patients on dialysis, we don't do it at all. We use only CGM. And there's another test called glycated albumin, which is better than fructosamine, in my opinion. And that can be used, but it reflects only 1 month's control. So you'd have to do it more frequently. But I think it gives you a very good index, particularly when you're changing treatment and you want to see that someone is doing better. And we've written papers about this. In terms of CGM, some people are doing it all the time, particularly those taking 3-4 injections of insulin. However, we have another option for CGM, which is called professional CGM, where we lend the patient, like doing a Holter monitor for 2 weeks. They are blinded. They don't see it. We know what is going on in their real life. They write a little diary. They bring it back. We download it. And then you can have a very good discussion with them. I use this a lot. I think it's a very useful tool, and I think it should be used more.
Vijay Negalur, sir,
I think I agree with him what he said. We also used a lot of CGM, and we have both the professional one and the patient also sometimes has a reader. So you can find out the glucose values, and based on that, he can adjust the dose, both of insulin and oral drugs. We've been using it very often. One more test which is likely to come soon is 1,4-anhydroglucitol, which is also a drug which can tell us about the glycemic control over a period of 6 to 8 weeks. It can be sometimes used in patients who have renal failure. They can be useful. And even in pregnancy, it's useful because in pregnancy, A1C is also not reliable because the A1C is usually on the lower side. And also remember, in patients of hypothyroid, the A1C is spuriously very high. So these things one has to keep in mind, the limitations of every test. And then we should advise these tests to the patient so that the control is very good. And besides this, of course, we need to control the blood pressure, the lipids, the obesity, and if the patient has any renal impairment, that also has to be monitored very frequently. So it's very, very comprehensive monitoring to see that the patient doesn't land up with either cardio or renal problems in his lifetime.
Thank you, sir. So the second question is related to the dietary management. I presume there are a lot of queries all the clinicians receive on their diet. So there are specific queries like what is the role of keto and fiber diet and all this.
See, I believe in what I'm saying. It might sound like a joke. All diets work. They work in different people differently, and you find a diet that works, that is good for you. However, it's a diet for life. Most people diet for 3 months and they think, okay, I lost some weight, I'm done, this is great. And then they regain the weight. So I think people need to realize that dieting, lifestyle change is for the rest of your life. And you should persist with it. There's another very important lesson from the Finnish diabetes program. They looked at people who were successful long-term in dieting and preventing diabetes. And these people had repeated advice about diet for 3 years before it finally got in that I got to do this for the rest of my life. And the people stayed that. So I think meeting one time to talk about diet or seeing a dietitian once or reading one book once really doesn't work.
Yeah, I think I agree.
And if you do it in that context, some of the obesity drugs are actually very helpful in the context of people who are struggling after trying lifestyle and recognizing you got to do it long term.
Yeah, I think Margaret is a famous dietitian, and she said that it's difficult to change the dietary pattern. The patient might change the religion, but not the dietary habit. So that becomes very difficult issue. And since you pointed out about the fiber, I think the soluble fiber has a definite role to play in patients of diabetes, because once it gets digested, it produces what is called short-chain fatty acids. And these short-chain fatty acids do release GLP. And that's how the patient has the benefit of reducing some weight. It also produces some substances like acetic acid, propionic, and butyric acid, and lactate. And all these substances are supposed to improve the patient's outcome so far as the release of the GLP-1 is concerned. So therefore, I think it definitely has a role to play. And we have been using it. Of course, the Indian diet contains a lot of fiber, a lot of vegetable, fruits. They contain fiber, and the soluble fibers are useful. About the keto diet, many patients of diabetes, they restrict the carbohydrate so that they feel the control can be very good. Yes, it's possible. But when you take too much of fat, then you have only fat and protein. We have three components of macronutrients, which is either carbohydrates, fats, and proteins. If you restrict your carb to say 20%, you have to have the 80% coming from fat and protein. Protein you can't increase more than 20% because Indian diet, the best of diet has 8 to 10%. 30% protein is not possible. So remaining all becomes fat. When you consume too much of fat, what happens is your sugar might go down. You might lose little weight because all these ketone bodies work as the best diuretics, and therefore you tend to lose weight. But what happens is you tend to gain a lot of LDL values, and these LDL can be atherogenic. You might have the diabetes control but die of a heart disease. So I feel that's why this keto diet, which was a very famous diet by Atkin, who himself died of a coronary artery disease. He was a cardiologist himself in US who proposed this diet therapy, didn't do well. And as Vivian said, none of these fat diets work because they work for a very short while. And afterwards, more often than not, these patients stop this kind of a diet practice and they get back to their original schedule. So therefore, as Vivian said, that the diet should be for life. that should be way of life, and that should be continued forever and ever.
So just one point about ketones. There are some advantages to ketones. SGLT2 inhibitors, for example, to increase ketone production. But and those are thought to be good because ketones are a very good fuel for the heart and the kidney, and it's thought some of the benefits work through that. But let me point out, you don't need the drug to increase your ketones. Any calorie restriction will increase the ketones. In fact, we all have ketones if we miss breakfast, for example. So modified fast, some people are talking about those prolonged fast. You skip breakfast, or it's probably not a good thing because some people eat too much later in the day. So that's also not good. So if you're calorie restricting and you're doing that by missing one meal a day, you do get some ketone production, which actually after a while cuts the appetite as well and might have some other beneficial effects. The long-term benefit of that is not proven. The long-term benefit of calorie restriction is proven. Even with bariatric surgery, you are restricting calories.
Right. And all the data is the animal data on calorie restriction because that is not possible to study in human beings. So we have
moderate calorie restriction, like in the diabetes prevention program, where you're reducing calories by only 5 to 10%. That works. Modest exercise. You can't go and run a marathon if you have obesity and heart disease and you're 65 years old. But you can walk for 30 minutes a day. I think that is really what we should be getting at.
Right.
So we move to the next query, which we are researchers. So as we all are observing that diabetes is now quite common in the younger diabetes patients. So what would be the right approach to manage these young diabetes patients, newly diagnosed?
I think in general, the approach is the same, except for 2 or 3 important considerations. Number one, don't miss type 1 diabetes. I see this a lot. I see people who are very young, sometimes 18 years old, who are obese. A lot of obese kids in the US. They get diabetes, and the doctor starts metformin, saying he's got type 2. He's got obesity and type 2. And then the patient comes 2 years later with a blood sugar of 400-500 because they fail to recognize that this patient has type 1. They have not yet got ketoacidosis, but they have antibodies that are positive. They're not making insulin. It becomes very challenging to treat people like that with insulin because they gain even more weight. But the fact of the matter is you should not miss a type 1. Secondly, if they are obese, weight loss is critical. I think these younger people need to realize, and there's lots of good data to suggest that if you get type 2 diabetes at a younger age, your risk of complications in 20 years' time is much more than people who get it at a later age. So if you get diabetes at, there are a lot of people who get diabetes related to aging at 75, 80. We don't need to be too aggressive about treating them because 20 years later, they might be gone with something else. So you don't want to reduce risk of retinopathy too aggressively. Yes, you want to, but not too aggressively. But in a 25-year-old, they have a life expectancy that they want of at least 50 years, maybe more. And their chance of getting complications of diabetes is almost close to 100% if they don't take it seriously. So I think that message needs to be given to them. They need to be treated more aggressively, maybe seen more often, and given this educational message and stay on top of the disease. Because as you see from grade, it progresses. And if you wait too long, it's going to keep progressing. Doesn't matter what treatment you use initially, just get that A1C down and keep it down. Treat the lipids and blood pressure and body weight. You're good.
I think you should also remember the possibility of MODY variety in younger generation. And also in India, we have FCPD, which presents with abdominal pain to begin with, and eventually they get diabetes. Though they have a severe beta cell deficiency, but they don't get ketosis. They have abdominal pain. A simple plain X-ray of the abdomen can make a diagnosis of FCPD. And these patients also will require insulin. And eventually they might get an exocrine pancreatic deficiency also. And I think MODY and this FCPD should be kept in mind. And what's very interesting is that the younger generation, the lifestyle becomes difficult. It is difficult to tell them about restriction of calories, restriction of, and the activities becomes quite difficult. And especially if the children are very obese, then they do not really do extremely good so far as lifestyle is concerned. So that becomes challenging. And when they go into puberty, there's a surge of insulin resistance, and these patients who are otherwise well controlled to begin with suddenly go off control when they get themselves into puberty. So these are some of the points which should be kept in mind when you treat the younger generation of type 2 diabetes or diabetes in general.
Thank you, sir. So one query which has come, which is very common in Indian scenario, is use of multiple forms of medications, allopathic and Ayurvedic. So can they be used simultaneously?
See, the problem is very impossible to answer that question because there is no data. I have a very old saying, in God we trust, the rest have to show us data.
Right. In fact, I've seen the other side of the story. In fact, most of these patients come with problems. I had seen one patient who consumed this Ayurvedic medication from Kerala. Kerala is one place where a lot of Ayurvedic medications are practiced, and these patients came with the abdominal pain, and when we found out, it looked like that the patient has acute appendicite-like picture. Then we did the ultrasound. They showed some shadow. CT abdomen showed a huge area of something like calcification. It was found to be asbestosis, which is a kind of unusual manifestation coming as abdominal pain. So I personally believe the medicines of which you don't know of pharmacology, you don't know about the distribution, the way it is metabolized, the way it's excreted, better not to fall a prey for such medication, because diabetes is a lifelong disease. You can't play with it by using these kind of drugs which are not authorized, not studied, and not well documented.
There is it's not unique to India. You see this in China a lot, actually. And I'm sure some of it occurs in various parts of Africa. It just doesn't get enough attention. As you know, I've been a journal editor for many years, and I get many, many papers from some of these countries on claims for natural therapies that are so wonderful.
Yes.
But they just don't have good quality data.
Yes.
We can't publish it because the studies have not been done properly. So whenever people like to believe what they want to believe in, they see something, somebody tells them anecdotally, and today we have another problem, and that is all kinds of information put out on Facebook and internet that people they'll believe that rather than believe the doctor. It's a very sad situation,
Yes.
and a lot of misinformation. And Facebook is under a lot of attack for misinformation right now, and so should some of the other platforms. You would not put that in a peer-reviewed medical journal where you have certain standards, and I think people need to be educated about that.
Right. I think I remember a patient of mine who used to go into hypoglycemic episodes very frequently. When I took a detailed history of this patient, he revealed to me that he's taking some Ayurvedic powder, which is very effective and powerful. So I was really intrigued. I said, get me the powder. I got it analyzed. And to my surprise, it contains sulfonylurea. So a lot of these quacks also use these drugs and powder them, and they sell them as the Ayurvedic medications. Actually, they are not. And what they give is these medications powdered, and they give in their own special formulation saying that this is the drug which is better than what your doctor has prescribed. I think one should not fall to prey to such kind of false promises by these quacks, and should refrain from taking these medications. That's my advice.
Yes. So now we have got multiple questions. I will club this question together. The question is related to pre-diabetes and borderline diabetes. How do we manage pre-diabetes and borderline?
So the data is very strong on lifestyle change. Modest lifestyle change, like we talked about, reduces the conversion to diabetes by 60% over 3 years. Very, very effective. Metformin reduces it by only 30%. And that is because, again, I want to emphasize the title of our program today is on precision medicine. Metformin works very well in obese people who are young and have a high fasting glucose. It has nothing to postprandial glucose, which is a big problem in the Indian population. So metformin is not the ideal drug there. So what would be the ideal drug? And then several years ago, a study from China on acarbose, there was a study first that showed with acarbose you might get reduction of postprandial glucose, but there were a lot of claims made of it, and a recent Chinese study done in collaboration with Oxford did not show a great benefit of acarbose. So you could choose some of these things, but when you look at it, the lifestyle change beats it. And this is not in Chennai. Dr. Ramchandran has done an Indian diabetes prevention program, which is, I think, a great study, a properly done, well-conducted study, like the Finnish study, like the diabetes prevention program, that did not show a very great benefit of drugs, but a very good effect of lifestyle change. One other new bit of data just came out a couple of weeks ago on the diabetes prevention program. Metformin did not reduce cardiovascular events in that population, and it did not reduce cancer rates were quite high over time, and metformin did not reduce that. So, for some people who've been grabbing snippets of data who believe these things, I think it is very sobering that when you really look at data consistently over 15, 20-year period in a well-studied, well-followed population, that is when the real truths are revealed.
I think nothing more to add from my side, but except the Indian Diabetes Prevention Program used metformin 250 milligram twice a day. And we asked Dr. Ramchandran why did he choose this dose to use in these patients. He said that he witnessed some patients having hypoglycemic episodes. So therefore, he used, though it's very uncommon to see hypoglycemia with this drug, but I think when everything is combined, maybe there was hypoglycemia. So therefore, he resorted to use 250 milligram twice a day. And the weight loss that we saw in the Indian Diabetes Prevention Program was far less compared to the Western, the Diabetes Prevention Program, where the weight loss was quite significant. Of course, the 8% weight loss was not achieved by large population, but whatever they achieved weight reduction, because basically to begin with, these people were obese, and that was not true in Indian population. So therefore, we didn't get the similar result that we got from the USA Diabetes Prevention Program.
Even so, I think that we have to give a lot of credit to that study. It was well conducted.
Yeah, it's well conducted.
There are limitations of what is chosen. They're chosen for good reasons at the start. You just have to recognize it for what it is. There is a big benefit of lifestyle change.
Yes.
And even modest weight loss in a population that is not obese to start with is actually quite beneficial.
Right.
Thank you, sir. So there is one interesting question related to patients of type 2 diabetes having tuberculosis as a comorbidity and patients having challenge in loss of appetite and loss of weight. So what would you advise on managing these patients?
Many of those patients have very poor diabetes control and poor general ill health. You have to manage all of it together. The weight loss is not always due to diabetes. You have the underlying tuberculosis. You have to provide adequate nutrition. We actually it's almost counterintuitive that you have to give them more calories and then give them more insulin to cover it. We use sometimes supplements, these liquid supplements like Ensure and things like that have a lot of protein, but some carb as well. Keep the blood sugar up and give insulin. All that together has a anabolic effect that is beneficial to the patient in the long term, while we should not forget the anti-TB treatment. The diabetes treatment alone is not going to cure the TB.
And quite often there is a drug-drug interaction between tuberculosis drugs and the diabetes drug. So that becomes difficult. And that's why we need to give insulin to these patients. As Dr. Vivian said, that it has anabolic property, and that will help the patient to gain weight and also gain a lot of appetite, because both the anti-diabetic drugs and anti-tubercular drugs, both of them reduce appetite significantly. So that catabolic effect can be negated to some extent by giving insulin. And of course, the calorie consumption should increase, because every 2,500 calories you consume, you gain half a kilogram weight. So that has to be also emphasized to the patient. So high caloric intake is essential in patients who have such a severe catabolic state.
So we would like to take two more last questions, sir. One is related to the difference in readings between CGM and glucometer.
So there are many reasons for that, and people need to understand there will always be these differences. CGM is measuring interstitial fluid glucose, not blood glucose. Finger stick blood glucose is capillary blood glucose, and venous blood is also different, and arterial blood is different. The glucose levels are going to be different. You cannot help that. Secondly, these drugs were not, these devices were not designed to be the absolute gold standard precise measurement. Even glucose meters are not precise. The FDA approves meters that have 10 to 15% variability on either side of the true mean done in a reference lab. They are there to tell the patient, give them a guide of where they are approximately. The most important thing, though, is recognizing hypoglycemia. And that is where I think CGM has some problems. They sometimes give you an error, but it's better to have an error warning you may have hypoglycemia than to not have a warning. So I think all in all, despite those limitations, these are all very good tools. We had a problem with the sticking of the fingers, doing it frequently enough, and the pain and discomfort and lack of compliance with that. Now we have overcome it with CGM. I think we should embrace it, and hopefully the costs will decline. We'll have more different devices, and this is going to be really the standard of care for diabetes.
That's fantastic answer. Nothing to add.
So I'd like to take the last question, sir. It is related to SGLT2 inhibitors. So the question is, are there any safety concerns with them?
Well, there are certain safety concerns that I think are very important. One is you have frequent genital infections, and occasionally, it gets out of hand. It's not a common cause of pyelonephritis, but you might get an occasional patient who has an infection there. The most serious one is risk of ketoacidosis, particularly in patients with type 1, people who have type 2 on insulin. They get hypo, they stop taking the insulin, and actually they have type 1 and didn't know it. They get ketoacidosis. Or they get sick and they don't eat, and they get ketones from that, plus the ketones from the SGLT2 inhibitor makes the situation very much worse. So that can be very bad because they keep excreting glucose. So the glucose is normal. The patient goes to the emergency room. They say glucose is normal. They don't think of a DKA, and the patient says, I'm breathless. Well, they're breathless because they're acidotic, and it's not as if they have a lung problem. And it goes unrecognized for several hours, and some people have died as a result. So the FDA has refused to give approval for these drugs for type 1. Very recently, I heard that they might stop it. They got approval in Europe, but they might stop it. AstraZeneca actually put out a press release withdrawing marketing of dapagliflozin for type 1. I'm not sure why, but I suspect that this is one of the reasons. The second thing, or the third thing that we need to be careful about and watch out for, you have heard of controversies. Does it increase fracture? There's no effect on bone, but people may fall with postural hypotension, particularly older people. People who are taking other antihypertensive and diuretics, they might get dehydrated. They may have more falls. And also you are, when you reduce the blood pressure rapidly, as can occur with that, your peripheral blood flow might be affected. So people with bad PVD, people with, previous stroke, I'm very cautious about using it. The benefits are small. Unless they have severe heart failure, the benefits are actually very small. So I think that you want to first do no harm, and there I would use other drugs like GLP-1 receptor agonists or thiazolidine.
It's quite disturbing the mycotic infections also, because many of these patients have balanitis, balanoprosthitis, and quite often sometimes you have to stop this medication or you have to co-prescribe the antifungal drugs. But the combination with DPP4 inhibition along with SGLT2 to some extent mitigates this issue of fungal infection. And therefore that becomes a major concern, especially in those people who have a poor hygienic condition. And in India, especially in females, this is very common, and many times we have to stop this medication because that's quite disturbing to them. But then the local treatment and sometimes systemic treatment and the good hygiene can overcome this, and the combination with DPP-4 can overcome this problem.
So although we have multiple questions, but due to time constraints, we would like to stop over here.
It's past 10, yeah.
Yeah. So at the end, I would like to, on behalf of the Sun Pharma, I would like to thank both of you, sir, Dr. Vijay Negalur, sir, and Dr. Vivian Fonseca, sir, for sharing the enormous experience, and Dr. Vivian Fonseca, sir, for covering so many patient profiles, almost covering the entire diabetes, different patient profiles in a short span of time. And both of you for taking queries and answering to them in a very patient way and an elaborate way. I would also like to thank all the audience for taking their time out and joining us on this in the month of November, where the World Diabetes Day is observed. And at the end, I would also like to thank the entire team who has been involved in organizing this webinar, virtual webinar on the diabetes. There are a lot of colleagues who are involved in this program. A big thank you to all of them. And at the last, also the back-end team, without whom it would not be possible, for all their kind support in making this event possible. Thank you all once again, and stay safe. Thank you.
Thank you also, Sanjay, for doing this program very well.
Thank you very much.
It well, and of course, connecting me to Vivian. I think we hardly met the last 2 years because of the pandemic. Maybe next time, probably for the ADA, we will see each other. But it was a fantastic talking to you, meeting you, and listening to you.
Thank you.
And great wisdom. Thank you very much. Thank you.
Thank you. Thank you, Sanjay.
Thank you.